Good afternoon, everyone. I'm going to talk to you today about the new epidemiology and prevention of type 2 diabetes. Now, this is a very vast topic. So what I intend to do today, and it's something like a disclaimer as one of my friends was telling me, because it's such a vast topic that I'm not going to be able to cover everything that has happened in the last, say, decade or so in terms of epidemiology and prevention. I'll touch upon some important studies as well as some of the important data that's interesting going forward. So if you look at the last 3 decades, the number of people with diabetes worldwide, globally, have more than doubled. And that is something which is known to everyone. And the data says that at least 1 in 11 adults globally in the age group of more than 20 have diabetes now. What is worrying, and I think that is again a trend that we are seeing in clinical practice, is the fact that both type 2 as well as pre-diabetes is being observed more in children, adolescents, and young adults. And I think that is the biggest concern that all of us have. Now, we know the reasons for this to some extent, and I don't think we have satisfactory explanation in terms of pathophysiology still. There are so many avenues that have opened in terms of pathophysiology. I'll try and touch upon a few of those. But it is clearly a complex group of genetic and epigenetic systems interspersed with behavioral and environmental influences. So quite a complex picture when you look at it. So although we would like to believe that type 2 diabetes is a very simplistic disease and we could easily treat it, it's a bit more than that, as we all very well know. Now, if you go back to 1980s, there were data to say that the prevalence of disease was less than 1% in China. I'm not sure whether that is very true, but I think that was a kind of data. Perhaps it was less of pickup, maybe the diagnosis was poor. I'm not sure about that, but there is data in the literature to say that 30 years back, the data in at least in some place in China, it was very, very rare. However, things have changed significantly, and the higher rates are observed in many Asian countries, not only in India. Now, there was evidence that this is going to happen, because if you look at people or certain studies that have happened in Western countries, looking at the minority population, that is Asian Indians and Chinese, there was evidence that if you are exposed, perhaps if you are exposed to the kind of Western lifestyle, we or the Asians have a higher risk of developing these diseases. So there was some evidence that this could happen in our country once the rapid economic development and urbanization and nutritional transition happens. And it looks as if that's what has happened. Can you move the slide, please? Yeah, thank you. So if you look at the numbers, so where are the biggest numbers? Actually, China is leading now, followed by India and US. And again, this is something which we all know. We have seen these slides many times. But this is the kind of numbers we are looking at. So huge explosion of an epidemic. Yeah. So that's what we are seeing. Now, if you look at the increase of both diabetes and IGT over the last, say, 20 or what is projected into 2030, is that almost everywhere, globally, all over the place, there is going to be an increase or a significant increase to the tune of about 50% in all countries. Now, I remember about 10 years back when we used to look at these slides, we thought that perhaps this is an overestimate of this. Maybe that numbers are very high. But what has actually been shown in studies is that the numbers, we have probably underestimated the numbers. And it's perhaps more than what we had thought. That is the way things are going. So it's a standard slide that we put in all diabetes talks. And 10 years ago, you start the talk with that and you'd have all seen it 100 times or 1,000 times. But clearly, this is something which is happening right in front of our eyes. And the numbers are exploding, both diabetes and IGT. Now, what is unique to developing countries? And I think that's more important for us to look at. the first point is that the proportion of young to middle-aged individuals is much higher in developing countries. So the people with diabetes and IGT are getting younger in the developing countries, all over the world, of course, but more so in the developing countries. And the so-called rural-urban divide that was seen before is becoming less apparent. So there are data now from China as well as India showing that both in urban and rural, there seems to be a proportional increase in the diabetes. So that kind of divide that was there before seems to be less apparent now. So maybe even the urbanization is really starting to affect the rural as well. Now, if you look at some of the American data, type 2 constituted just less than 4% in children. If you look at the children, so if it is 2 decades ago, only less than 4% of children. So the rest was type 1. So whereas now, if you look at certain populations, not all Americans, but the migrant population like American Indians of course being the indigenous, but the Asians and Australian population, 80% of new onset in children seems to be type 2. So that kind of tells you that it is just the whole epidemiology has changed in 20 years from becoming children type 1, that is what we have been taught even 15, 20 years back, and now it is not. Children, you really have to think, is it type 2 first and then type 1? Of course, if your presentation would help you with that, but still. So things have changed dramatically when it comes to that. There is also that ethnic variation that I was talking to you about, which is there is a high-risk population or a high-risk minority in, if you look at US data, in Native Americans, Australian indigenous population, Africans, Asians, Hispanics as well. So they all have very high risk of developing type 2 diabetes. Now, what about the pre-diabetes? It's just not the diabetes alone. The pre-diabetes is also getting very, very common in the young. And there is data that there is almost 87% increase in the prevalence of impaired fasting glycemia and impaired glucose tolerance. So that is again a rapid change that has happened in 2 decades. For such a common disease, it is really worrying when you see those sort of data. And perhaps there is positive data from China and India, which are the biggest countries. However, it's certainly that is a field that they are younger, they're getting more diabetes, they're getting more pre-diabetes, and all the complications as well. Now, the modifiable and non-modifiable risk factors, something which we all know very well, but that list is ever growing now. I mean, this is something which many of those are things that we discuss every day with our patients as well as with our colleagues. But there are newer factors that we should be aware of. Perhaps we may not be able to change very much now, but over time, that is what we hope will happen. Things like the intrauterine environment. We need to give more focus on those aspects. So I'll come to those in the next few slides. So what are the new insights we have over the last 10 to 20 years when it comes to type 2 diabetes? I think it is very clear, all of us know, and all our patients know, that overweight or obesity is the single most important predictor of type 2 diabetes. And it's actually stronger in younger adults. So the younger you are, the more overweight you are, the higher the chance. And that has actually been shown in this study called the European Prospective Investigation. So what they have shown is that if your weight gain is before the age of 40 versus weight gain after 40, you have a higher risk. So that means if you're younger and you gain weight, then you have a higher risk of disease. So those of you here above 40, I think if we probably can put a little bit of weight and can get away with it, but certainly not the younger ones. Now, there is also that concept of the metabolically obese phenotype. And this is again something which we have, I think the previous speaker was alluding to as well, about the thin fat intent, the metabolically obese ones who have abdominal fat. So that has been used as one of the explanations for people who have the BMI, which is not high, but who have type 2 diabetes, insulin resistance, and all the other complications. So that is a concept that is again been suggested. Now, if you look at some of the other data, I mean, this is looking at more than 2 lakh individuals from 21 studies in Asia and Pacific region. What is clear is that the waist circumference seems to have a stronger association with type 2 diabetes than BMI. And this again something which we all know, I mean, which is why we use waist circumference as one of the parameters. The other thing which all of us have become aware, perhaps again in the last few years, is the non-alcoholic fatty liver disease. And it's just become so common. There's so many doctors, including who don't drink but have alcohol, have chronic liver disease. And it's clear that NAFLD has got a very strong association with peripheral insulin resistance than the abdominal fat content. And there is again a meta-analysis to suggest that if you look at ultrasound diagnosed NAFLD and elevation of its surrogate markers, there is a consistent relationship or prediction of type 2 diabetes with that. So NAFLD is something, I mean, we see pretty much every patient of ours who goes and have a scan, the report will come back as mild fatty liver, and we chose to disregard if the liver function blood tests are normal, because there are so many other things to discuss with a patient in a clinic setting. But that clearly is something. I mean, especially when you are non-diabetic or a pre-diabetic and have non-alcoholic fatty liver disease, that's the time to think that these are people who are going to move on to the diabetes. I'm still having problems with the slides, I think. It's not moving. Yes, thank you. Now, this is something which the last debate was about. This is the effect of very low calorie diet and the effect on reversal of diabetes, not cure of diabetes, reversal of diabetes. And I wouldn't go too much into it because Dr. Jayashree and Dr. Vijaykumar had discussed at length for the last hour or so. But it is clear that the ectopic fat deposition in the liver and islet cells might be playing a part in development of insulin resistance and beta cell function. And this was that hypothesis that Professor Roy Taylor had initially proposed. So this was just a proposal, but then he elegantly did the direct study which came out in 2017 and 2019, and it looks as if you can lose weight above 10 kgs rather than the proportional, it seems to be that 10 kg is a factor, is a magic number, about 10 kg and maintain it over a period of time, you can reverse diabetes in more than 50% of cases. So that is, it's interesting, it is very, very useful, it gives us a peep into the pathophysiology. How easy is it to practice in a primary care setting, in a community, is a challenge we are all going to face. Can you move the slide, please? Okay, so that's what we said so far. So the liver fat and the pancreatic fat seems to have some effect on the pathophysiology. Now, let us look at some of the other factors, and this is the epigenetics, again something that was touched upon by Dr. Vijaykumar earlier. What is epigenetics? It is clearly not associated with changes in the DNA sequence, but something that involves DNA methylation and histone modification. So these are the seeds of a disease that is being set in utero or in a very early stage. And what has been shown is the low birth weight, which is certainly associated with increased type 2 diabetes in later life. And the concept of thrifty phenotype, that means those children who are have low birth weight and have gone through starvation seems to have an increased insulin resistance and increased chance of type 2 diabetes. And that again has been shown in some of the studies like this. That is the Dutch hunger famine study and the Chinese famine study. Again, what has been shown is those who have gone through a famine seems to have an increased intolerance to glucose, and they are people who have at higher risk of type 2 diabetes. So there seems to be some sort of fetal programming that is happening to beta cells as well as to the whole pathophysiology in type 2. Now, add to that is a high birth weight, which again is something which we know. So it's something like a J-shaped curve or U-shaped curve or whichever way you want to say it. But the high birth weight is also associated with an increased risk of type 2. And it is a two-edged sword, isn't it? I mean, when you have this, it predisposes both mother and offspring to the development of obesity later in life, in developing metabolic syndrome, as well as type 2 in later life. So both mother and offspring have that risk when you have fetal hyperglycemia. So this is one area where we can make a big difference. So that is a gestational diabetes, isn't it? Because we know more than 7-fold increase of type 2 is there in those with gestational diabetes. So the intrauterine hyperglycemia, as I said earlier, will affect not only the mother, but the offspring as well in later life, in terms of everything, in terms of obesity, in terms of pre-diabetes, as well as type 2 diabetes. So it is something like a vicious cycle, isn't it? The diabetes begets diabetes. So if mother has diabetes, then or mother has pre-diabetes, mother is going to develop diabetes later. If mother has diabetes, then the child is also going to develop diabetes later. So it's a cycle that perhaps one opportunity for us is before they become pregnant. Now, what about the genetic susceptibilities? So we have talked about the epigenetics briefly. The genetic susceptibilities, unfortunately, this data has been fairly disappointing, because although there have been a number of genetic loci that have been associated with the risk of type 2, the discriminative ability of genetic scores based on risk alleles is unsatisfactory. That is, the chance of you predicting based on all these alleles, all these genetic loci, seems to be still quite poor. So you can always say that one person has 10 genetic those risk factors. However, it still is not good enough to predict it. So I think that is where it has been disappointing. I'm sure there will be more work in this area, more work that is ongoing, and we will get better results. But where it might be useful, and this is a point to note, is that the use of genetic markers might be of much more value in children and young adults, and that there is some indication that in children and young adults, you use this, you might be able to get a better, they might be better predictors. Now, there is other two interesting studies that have shown in this area, is that if you look at the Western diet pattern, and if you look at the men developing type 2 diabetes, it looks as if those with high genetic score are more susceptible to the Western diet. So that is interesting. So it looks as if you do a genetic analysis and if you find they are higher risk, that diet change might help. Or if they are on that sort of diet, maybe that can change. So that is one study that showed some indication on that. Similarly, there's some of the other lifestyle interventions, like even exercise. In those with high risk genetic features, they might be more susceptible, or they might get more benefit. So it might be that some of our interventions we could focus and program on people who have got high genetic probability based on the genetics. What about the other lifestyle and environmental risk factors? And each of these could be a talk by itself. So I'm just going to run through the sleeping disorders, depression, antidepressant use, endocrine disruptors. It's a full talk, or a full this thing by area by itself. And we know for sure that these are playing a major part, although we don't know how they are playing a part, isn't it? The particulate matter in air pollution, also there seems to be indication that it develops type 2 diabetes. What about the gut microbiome? I mean, area there has been so many interests and so much of talks that we have heard in the last 5-10 years. It looks as if the diversity and the composition of gut microbiota plays a part in development of type 2 diabetes and insulin resistance. And this is the next couple of slides just to show you that. The fact that it is just not the gut microbiota at a given time or when you're an adult. It looks as if it starts in utero. So your gut flora, when you're in utero, perhaps starts to, from then on, the seeds of this disease is laid. So things like, the infections, things like breastfeeding, all might have an effect on this. So the gut microbiota, I think we need a lot more information on this area before we can say for sure that they are playing a major part. And there is definite differences that we have found in people who have had, who have type 2 diabetes in terms of the gut microbiome. The leaky gut has been proposed. The metabolic endotoxemia, all these seem to be higher in people who have diabetes or who are obese. So clearly there is a change in the gut microbiota, which might be happening very early on, which might be contributing to the disease much later. Biomarkers and metabolomics. Again, there are a lot of biomarkers that have been identified, which might have ability to.
Doctor, you have 1 minute.
Yeah, a couple of minutes, and I'll just finish. Now, let us look at very quickly at the epidemiology of complications of type 2. I'll just take 2 minutes and finish it off. Sorry. So this is, so far I've talked about the risk of developing type 2 diabetes and pre-diabetes. But let's look at the complications and how has the pattern changed. It looks as if the current data, current prevalence data suggests huge numbers, 50% of microvascular, 25% of macrovascular complications in Asia and Africa. And there seems to be a pattern in terms of what has changed. So cardiovascular disease, for example, we know is much more common in Indians, but the rest of the Asian countries, it doesn't seem that it's that common. So that was again shown in the advanced study. So there seems to be an ethnic variation or ethnic difference. Renal disease, again, although renal disease is still, if you look at the renal disease and end-stage renal disease and mortality, certainly type 2 is one of the most important things, but even then it seems to be even higher in the Asian population. So looks as if ethnic variations exist over and above just the glycemic control when it comes to diabetic retinopathy. For some reason we seem to be more protected against diabetic retinopathy compared to the Western population. Again, something that we don't know, but there's very good data even from Chennai, from the Cure study from Mohan sir's paper, suggesting about 18 to 19% retinopathy versus 30% outside. Again, what we lack is population data, and I think that is an area where we are significantly lacking, because that means that we are unable to plan our population interventions. Now, there are some of the other studies. I'll just skip all the management studies. Let's just show this slide, which I think is very important before I conclude. So this is the data that came out in Lancet 2018. And what is interesting, this is looking at this interstate variation in type 2 diabetes in India. Okay? And what is interesting in this is that the prevalence, as you would expect, is more common in the so-called advanced states, which is Kerala and Tamil Nadu. However, what is interesting was that if you compare from 20 years ago, those states, Jammu, UP, Chhattisgarh, etc., seems to have the most significant percentage changes, because it looks as if we are already there and these guys are following us and reaching. So if you look at the percentage change, that seems to be more in less developed states. So clearly they are catching up in terms of disease, not good news. So I think in terms of planning for the disease, it is important that this data, more data like this is available. So I'll conclude by saying that it is a huge problem in developing countries. We all know that. What we are doing now is all that we can do at this point, but there is a lot of promise, a lot of hope in terms of all those pathophysiologies that I have said. There are areas where we might be able to intervene. And till we can get better answers, I think we should focus on what we are doing now, which is regular physical activity and lifestyle changes. Thank you very much. Before I stop, can I just tell you about this PACE Masterclass? This is a conference that the PACE, which is the organization, the endocrine organization of Kerala are doing. And we are going to conduct a symposium on differentiated thyroid carcinoma on 28th and 29th of September. So this is for a focus group for people who are very interested in thyroid cancer, who are dealing with it. So any of you in the audience who is interested, please contact us. Dr. Joe, who is secretary of our organization, is here as well. So please contact one of us and we will make the arrangements. Thank you.